Hi, my name is Reese Gay. I am the Director of Community Health here at Butterfly Network. And today we're going to be discussing from novelty to norm, the need for establishing an ultrasound first culture here in rural healthcare. So the agenda today will be pretty straightforward. So we'll go through a quick welcome. We'll introduce our guests. We'll have Dr. Peter Weimersheimer go through a case study of UVM's POCUS adoption journey. And then we'll be bringing in Butterfly Network's own Jill Kalman to join our panel for an executive discussion with Dr. Weimersheimer on once you have that vision of a POCUS adoption journey, how do you go implement it and how do you get support across the organization, while then coming in for a landing for a question and answer session. So starting off, 75%, that is the percent that rural hospitals claim to be doing point of care ultrasound. Now, what's interesting is once you dig into that number, it's roughly less than 10% are actually doing ultrasound from a point of care perspective today. The majority of them that are stating that are actually doing it because they are leveraging a portable ultrasound device 1 to 2 times a day, doing fast exams in their emergency department, and they're considering it POCUS. And so, meaning that there's truly a nuance between portable ultrasound and point of care ultrasound, and true point of care ultrasound. Now, here at Butterfly, we are big advocates for true POCUS. And for us, that means that a clinician would leverage a single handheld probe that is highly usable, highly portable, affordable, but most importantly, versatile. And then it would be leveraged by a provider and as seamlessly and as common as they would use their stethoscope today. So think of it like using a wireless landline phone that just made phone calls versus a smartphone where it could be used anywhere, at any time, and would be much more powerful with a lot more function. And working with our healthcare providers today, we're most commonly seeing that they're leveraging our probe, the IQ Plus, in really the main ways. First being fast exams, next lung assessments and line placements, which are pretty standard ultrasound procedures. In addition to that, they're leveraging our IV access with what we call biplane, where they're able to see both planes of the vein as they're coming in for the needle, which allows for them to be more accurate. And also differently, they are leveraging our IQ Plus as a bladder scanner. So a lot of really unique applications there. And really what makes this all possible is Butterfly Network's chip-based ultrasound technology versus your traditional crystal-based probes, which this allows for the need of not needing multiple probes, flipping a handheld device over, right? So the usability to get a different scan is a lot more seamless. And that chip technology allows for traditional POCUS adoption barriers to be removed by making the IQ Plus more portable, usable, affordable, and allows for them to seamlessly pick up a probe and leverage it in multiple different capacities. Simply put, POCUS is hard, right? It's tough stuff, but Butterfly is here to make it easier. Which I believe in a rural healthcare setting where you have 1/6 of Americans getting their care from today, there is limited access for imaging. It is a point, we're at a point that ultrasound really can help assist in this and help assist rural health clinicians in expediting their time for treatment and promoting higher patient satisfaction. So today we're here to learn from two great physicians on how we can better do this. First and foremost, we have Dr. Peter Weimersheimer. He is a professor of surgery at the University of Vermont, and he's been practicing here for 28 years. He is the founder and director of the University of Vermont Emergency Ultrasound Section and the UVM EM Residency POCUS curriculum. Also runs a 4th-year medical student elective in point-of-care ultrasound. Peter is the regional director of clinical ultrasound for 7 UVM Health Network emergency departments, and he helped develop their global credentialing and practice standards within the system. He's a professor in the Ultrasound Leadership Academy, as well as he lectures, teaches, and mentors physicians internationally. Most recently, was the co-director of a lung and critical ultrasound course in Uganda for the management of COVID-19. Secondly, we have Dr. Jill Kalman. She joined Butterfly Network as our Chief Clinical and Scientific Officer. She leads strategic partnerships, which collaborates with industry across multiple business lines to create unique partnerships that will mutually expand markets. Dr. Kalman is a cardiologist by background and is an expert in congestive heart failure. She has directed multiple heart failure programs in New York City, but most recent positions were as a healthcare executive, where she was the chief medical officer and subsequently the executive director at Lenox Hill for Northwell Health for the past 6 years. At Northwell, she was also the medical director for the Office of Patient and Customer Experience across all of Northwell, which she led initiatives focused on the physician's role in the patient experience. So with that being said, I'd like to pass it over to Dr. Weimersheimer to discuss his adoption of, or UVM's adoption journey around changing the POCUS culture.
Thank you, Reese, and really honored to be part of this discussion and really excited about how we can promote using ultrasound for clinical care. And this discussion is going to be about my version or one version of how to implement ultrasound in a rural setting. It's really a discussion in general about medical culture and the evolution of medical practice. And what do I mean by that? Well, whether you're a medical practitioner or a medical consumer, the concept is that over time, medicine evolves, and what was once a standard changes to become a new standard based on new technology, new information, new guidelines, new interventions that change patients' outcomes for the better. And ultrasound is not new. It's been around for over 30 years, and I've been lucky to have been involved with clinical ultrasound for over 2 decades and has worked as an ultrasound educator for that period of time as well. And as powerful as ultrasound has been for myself in clinical practice, and as much literature that exists about how important ultrasound can be in the clinical setting, I have to say that as an educator, the biggest challenge is to get clinicians that sweet spot where they conceptualize that ultrasound is not just this cool tool that's available once in a while, as you mentioned, Reese, for an EFAS in a trauma patient, but that with its regular use and aggressive use early on in the course of patient management, ultrasound can have dramatic effects on patient care, and in a rural setting can have a dramatic effect on downstream management. Does that patient need to be transferred? Do they need a higher level of care? And that imaging can be such a crucial adjunct in answering that question. Now, I'm an emergency physician. I work both at a tertiary care medical center, and I work at community hospitals and critical access hospitals as well. And in emergency medicine, ultrasound education has been part of the emergency resident training curriculum for now about 8 or 9 years. And it's also part of some other subspecialty training as well. It has not been incorporated by many specialties yet as an integral curriculum, and many medical schools yet do not teach use of ultrasound in the clinical setting along with other testing paradigms that we learn. And the intent of trying to have ultrasound more at the forefront of education is because no matter what specialty or subspecialty or urban or rural, we all do the same thing clinically. What does that mean? We all try and meet our patients, take a history, risk stratify what they're presenting with, and then use our skill set to figure out what they have and what's the best intervention so they have a better outcome. And many times this is always based on taking a history, we auscultate, we palpate, we look, listen, and feel, and sometimes that's enough. Sometimes somebody's coming with a likelihood of a disease that's relatively low risk, and we can make a clinical decision and manage that patient just on our clinical skill set and gestalt. But the reality is in modern medicine, especially when we work in more high acuity settings, this is not so easy. And in general, we have to do other things, other tests, other interventions to answer the question we're trying to ask. And all of us who have been clinical practitioners have had the experience of a patient who's coming in with a seemingly benign presentation who has some truly catastrophic event that's happening as we're doing our assessment. And so the challenge in clinical medicine is to be able to rapidly understand what our patients are presenting with, what do we need to do, what interventions are optimal. And that is hard. It's a challenge. And it's a challenge, especially in settings where all the testing equipment may not be available at the time we want it. And here's some examples of cases that I've heard about from across the country of specific patients. Here's a 2-year-old young girl who's brought in by her dad to an emergency department. The child has had a fever for maybe 2 to 3 days, has been a little punky, cough, runny nose. Mom and dad have been giving acetaminophen and ibuprofen. And the kid picks up a little bit after that intervention, but then is declining. And this evening when dad came home from work, really seemed worse. And so took the child to the local emergency department for evaluation. And at that department, the child's initially seen by an emergency medicine resident, a first year who's actually trained in clinical ultrasound. And as part of his assessment and risk stratification, he takes that ultrasound, puts it on her chest, and he thinks he sees a right lower lobe infiltrate. So maybe this child has a bacterial pneumonia. Now, the child gets acetaminophen and ibuprofen at triage. By the time the resident and the attending go back to the room, the kid is just bouncing off the walls, looks great. And the attending is not as trained in lung ultrasound and orders a test that they are familiar with, and that would be a chest x-ray. And the chest x-ray is negative. Now, so here's a child who looks great, has come in with kind of a febrile illness, has a negative chest x-ray. They talk to the PCP, who also is familiar with chest x-ray as a risk stratification tool, and ultimately they decide to send this child home for outpatient follow-up. Unfortunately, 2 days later, the child comes back really sick and has to go to the operating room for an intervention to get pus out of their right lung space. Here's another case. This is a young man in his 30s. He has a lifelong history of asthma. And what asthma means for him is that every once in a while, he has to use more of his inhalers than normal, and sometimes he even has to be on oral steroids because he has a flare of a difficulty breathing. And he's familiar with what that feels like. And he comes into an emergency department because he's not responding as well as he usually does. He actually has been taking his beta agonists more often. He's been taking some steroids he had in the medicine cabinet. And he's actually also concerned that he might have COVID because something's just a little bit off. And he also was evaluated by 2 physicians, an emergency medicine resident and an attending physician, both of whom understand how to do lung ultrasound. And they see him and they do the usual for asthma exacerbations. He gets treated with betas, he gets more higher dose steroids, and he's feeling better, but he endorses that he's not just quite right. So they do another test to risk stratify this man, and they order a chest x-ray. And that chest x-ray is, again, negative. And so they decide that and he decides as well, like he's almost back to baseline. The x-ray is negative, the COVID test is negative, probably okay to go home with higher dose steroids. And luckily or unluckily, depending how you want to look at it, as he is waiting for his wife to drive him away from that medical center to their house about 40 minutes away, he collapses. And he's rushed back into the emergency department, and he has a massive blood clot inside his chest. And they give him clot busters. He gets resuscitated, and he does well. But, it was a scary moment. And there's 3 important points about these cases in terms of how you think about ultrasound or think about testing in medicine. The first part is that both of these cases were really common presentations. Whether you work in a rural community or in an urban community, at a clinic or emergency department, we see kids coming in with febrile illnesses, snotty noses, difficulty breathing. They're a dime a dozen. And most of them are viral. Most of them get better and do fine with minimal intervention. Similarly, we see asthmatics every day. And they have flares. We give them more steroids and betas. Usually they do nothing else. They do fine. But the second point of these cases is that in both of these cases, that sixth sense, that clinical exam, spidey sense of the providers was concerned enough that they wanted to order a test to really vet whether the patient had a more benign condition or a more severe condition. So they ordered that next test. And in this case, they ordered the chest x-ray or selected to choose to hang their hat on the chest x-ray results. And unfortunately, that test was not sensitive enough to make the correct diagnosis. And the third point, and this is how medical practice happens, is because there was a test which was negative, the providers did not change management. There was nothing in their findings of that test to say that they should do something different besides the usual care. And for both of these cases, the trajectory of disease was not going to be better without something else happening. Here's another case. So this is a very sweet young woman, and she's 75. She gets up in the morning, she has breakfast with her husband, and as she's having breakfast, she gets really lightheaded, a little confused, and gets pale and pasty. She feels horrible, a little nauseated. Her husband notes that and calls the EMTs, and about 20 minutes later, they show up at her house, and by the time they arrive, she's actually feeling a lot better. She really doesn't have anything that bothers her. They measure her vital signs, and she's a little bit hypotensive. Her blood pressure is a little bit low. But as they transport her to the local medical center about 45 minutes away, she's actually feeling back to normal. And even her vital signs, her blood pressure, and the things they measure are probably at her baseline. Maybe the blood pressure is slightly low for a woman in their 70s, but otherwise, she's back to normal. And so medical care, the way this gets worked up is pretty common in terms of what do you do when someone comes in who had something happen, now they feel better, and they have nothing on exam or history that you can hang their head on. So this is how usual care happens. This woman gets put on a cardiac monitor, she gets an EKG. That's normal, fantastic. This happened in the morning, she's on blood pressure medication, she takes diuretics, so maybe she needs some fluids. Maybe that would help her feel better, that's all she needed. But in most places now, we do things like blood work. So she has a bunch of blood work sent off to see whether there's something that they could hang their hat on. And she has all the things which are important for this type of scenario. She has usual blood work, but she also has a lab to assess if she had a heart attack. She gets a lab to assess whether she has a blood clot in her lungs. They do a lab test to ask if she's got systemic disease, if she has a septic presentation, and they send off a urinalysis to see if she has a urinary infections, because they can make this stuff happen. And all the lab tests, including those specific tests, are negative. Now, sometimes, more common in elderly patients, they can have what's called an occult pneumonia. They get a viral or bacterial infection in their lungs without being short of breath or coughing, so they order a chest x-ray, and that x-ray is negative. And then she was also altered, so maybe this is something intracranial, so they order an intracranial study, a CAT scan of her head, and that is also normal. And correctly, they can't figure out exactly what this is, but they understand that she's an older woman, she lives far from the hospital, and the correct thing is have her stay in the hospital on telemetry. Maybe she had a funny heart rhythm, and they even start her empirical antibiotics, and then they call the hospital service about having her stay. And so now she's seen by two other physicians, a seasoned attending and another internal medicine resident. And ultimately, they all decide this woman should stay in the hospital and should be observed. And what happens then is really what happens commonly in medical systems when we're so busy, and that there's a delay in getting her upstairs into a room. And so she waits in the emergency department for about 4 more hours until all of a sudden her husband runs out from the room and goes to the nurse's station and says, "Something is wrong with my wife." And the nurse and the provider at the station run in, and this woman looks awful. She has abnormal vital signs. Her blood pressure is really low. She looks pale and pasty. She's confused. And the provider grabs an ultrasound and gets this picture. Now, this is a picture of a heart. Right here is the heart. And above that, you can see here this black. In ultrasound, black is fluid. So this woman's heart is being compressed by this large amount of fluid that's between the heart and this membrane that surrounds the heart, the pericardium. So she has something called pericardial tamponade. So what happened at 7 in the morning? Well, at 7 in the morning, she had a spontaneous tearing of the vessel that goes from her heart all the way down to her body. She had a thoracic aortic dissection. This is a really relatively common condition, and it's incredibly hard to diagnose, and it's incredibly difficult to treat effectively. And she's had this condition, and the tests that were ordered weren't the ones that were going to pick it up. And so they do everything correctly. They go try and drain that fluid out. They start resuscitating her with pressors and get the surgeons involved. But as happens often with this disease, this woman does not survive. And here's a view of that heart beating with its pericardial effusion. And unfortunately, she has a bad outcome and doesn't survive. This is an awful case. This is clinical medicine. It's horrible for the patient and family, the providers who are doing everything correct and everything to try and make the correct diagnosis. I've had cases like this. It's devastating. You wonder, what could I have done differently? How could I have gotten the diagnosis more quickly? Could I have done an intervention which would have changed outcome? And this is internal medicine, this is clinical medicine, this is hard. But for the 3 cases I've just talked about, the common theme was that if an ultrasound might have been used early on in the course of clinical assessment, the first 2 patients had undifferentiated difficulty breathing. The third patient had undifferentiated hypotension. So asking the question with the ultrasound would have likely framed the diagnosis and might have framed management to happen more quickly. Would it have changed outcome for any of these cases? No idea. But the point is to try and use whatever tools we have at our disposal to try and understand what is happening with our patient. And in these cases, ultrasound might have been that extra tool that would have been helpful. Now, this is clinical medicine. Clinical medicine has really evolved to become more reactive, and especially in a rural setting where testing is somewhat linear. You see a patient, and then a patient gets something ordered that may happen at the site of evaluation, or maybe the patient needs to drive to get an imaging picture or to get a blood test. Then that information comes back to the provider who can adjust management and use that information to change course. But those of us who went into medicine, I think all of us who go to see a practitioner, really envision medicine as being proactive. I like being at the bedside with my patient when I can listen to them, I can do my exam, and I can ask a couple specific questions that may help me frame what's going on. And in this regard, ultrasound is a fantastic, proactive bedside tool to use with my patients. And all the things that people measure clinical performance with, what are metrics we judge or gauge how medical practice is happening, there's a lot of literature that supports that ultrasound is phenomenal at improving all of these metrics. It's a great adjunct. Now, as I said, I work in emergency medicine, and emergency medicine is higher acuity than primary care clinics in general, but think about what comes in to see me. The patients have certain common complaints, and no matter where they go, including in a rural healthcare setting, it's the same stuff. It's the same issues, and the acuity may be lower in a clinical setting, but there's certainly high acuity patients who will present anywhere. And as I've been doing ultrasound clinically and teaching ultrasound, these are the 11 ACEP applications that got taught in our residency training. I would argue that learning these applications is fantastic for patient care. But as we talk about how do you get ultrasound started and how do you implement it in new areas where it's not being used well, if I show this slide to anybody, all of you watching this slide, this is a headache slide, right? There is way too much stuff here to even think about. And if you try and think about, okay, I'm going to try and learn each one of these applications and be good at it, I think that's an overwhelming issue. Now, something happened over this past year and a half, which has really changed how I've thought about ultrasound education and ultrasound implementation that I think really was profound. Unfortunately, that thing was our pandemic. And the reason I talk about this pandemic, as you all may remember, hopefully remember, that when this started, it was an overwhelming process. We were all aware of a new infectious entity that's coming, and it was going to be contagious. It was going to have associated morbidity and mortality, and we all were really rushing to try and figure out how do we mitigate the transmission and how do we effectively manage patients with this. And in many hospital systems, what that meant was really closing down access to a lot of primary care, only because of not wanting patients to be contaminated and to get a really horrible disease. And that also meant that there were less availability of adjuncts and consultants. Elective surgeries were being postponed if possible to be safely, to not have the operating room itself become a vector for transmitting disease. And even some systems, there was an ask from radiology to avoid ordering testing that may not be necessary and may unfortunately contaminate radiology suites. So when early on in COVID, a CT scan might shut down a radiology suite for 2 hours, and that's a crucial tool that might be needed for people who are really sick. So in a sense, this outbreak had a lot of entities acting as if they were more resource limited. So similar to what happens oftentimes in some resource limited rural settings. What was prevalent in any setting was how to manage the clinics and the emergency departments safely. What that meant was we had to understand when people were presenting, they were generally sicker and they were often presenting with what seemed like viral symptoms, which may be COVID. And it's not that anything else that we were seeing wasn't as serious and we're still going to see those patients, but we were trying really hard to understand how to risk stratify those patients, who had what, and what's a safe, effective way to do that. Now, depending on where the patients presented, some patients are being cohorted into spaces. In our system and many other systems, patients were put in isolation rooms. And what that meant is the patient was in an isolation room. Anybody coming in and out of that room would have to wear full PPE. Early on, there was a concern we may not have enough PPE. We weren't sure that the masks we're using were actually effective. And so we were really concerned about not getting ourselves infected, infecting our colleagues and ED coworkers, other patients, our families. It was a really big deal. So for me, I worked someplace where COVID luckily wasn't as prevalent. Most of the patients who came into our area didn't have the disease. And the question was, how can we figure out how to safely risk stratify patients? Do they have this or not? Is there some way we can maybe do that in a more efficient way? And how do you do that? Well, you can certainly take a history, but COVID, like other viral syndromes, presents with very similar complaints. People are febrile, they feel lousy, they're short of breath, that type of thing. And then there's a clinical exam. And we've been using the stethoscope since 1816. It's a really great tube which translates sounds from the patient's body to our ears, and there's a lot of comfort in using it. It's very assuring to hear a patient breathing and to take those large breaths. And I think it's comforting for the patient for us to walk in and do that ritual where we ask them to take a deep breath. They can feel our hands on their body. But the reality is, in terms of how accurate it is for somebody coming with undifferentiated respiratory disease, it's a really poor test. It's hard to translate a sound to a clinical finding with certainty. And we stopped using our stethoscopes with these patients because we were concerned that it was more of a disease vector than it was going to be a clinical benefit. So what else to do? Well, there certainly is testing. So the problem with testing, in addition to the fact that it was a 2-day turnaround or wasn't available at the time that we were working, was that even when we got the results back, it wasn't a great test. That means a quarter of the time we did that test, it was a false negative. And so a single test just wasn't adequate for us to risk stratify the patients we're managing. So what else to do? Well, since 1895, plain radiography of the chest has been really the standard of how to risk stratify and assess patients who come in with some sort of pulmonary disease. Now, the data on X-rays has become more vetted with the presence of CT scans and outcomes, and it turns out that the sensitivity of X-ray hasn't been really what we thought. Now, COVID specifically, there was great data coming out of Italy, which really brought into question how accurate the test was. This is a patient who had X-ray, and there was a concern about them having COVID-19, and you can see that there's not a lot of reading here that makes sense that I can use. And in fact, if you compared the chest X-ray to CT scan in terms of outcomes, it performs really poorly. It means essentially half the time that I would be ordering a portable chest X-ray for a patient I thought may have this disease, the test was wrong. Now, when I've talked to my colleagues about the idea that the X-ray may not be the right test to do with patients who we thought might have a respiratory disease, the pushback was, well, we use this all the time for other alternative diagnoses, right? It has been the gold standard for years of pneumonia that if a patient had an infiltrate on X-ray, we would see that and diagnose pneumonia because of an infiltrate. But again, as we have better data with CAT scans and outcomes, it turns out that the X-ray isn't incredibly sensitive for even pneumonia. If I order a chest X-ray for a patient I think has a pneumonia, it's going to be wrong about a third of the time. That means a third of the time I've ordered the test, I'm not getting the right answer. And then there's congestive heart failure, another entity that we see often. And patients with CHF actually present very similar to patients who have a viral syndrome. They'll describe having progressive difficulty breathing, more fatigue. They may have a little bit of a low-grade fever or chest tightness. And so we've used the X-ray to diagnose patients with this disease or risk stratify them at least. And it turns out that the X-ray is about the same as COVID. It's very poor to actually diagnose CHF just by plain radiography. We have to do other things to risk stratify these patients. So The other issue for me about these tests is that to order these tests for patients who were in isolation rooms, we were asking radiology techs to wheel in this machine into our emergency department and to take this machine into a patient's room who may have a really highly contagious disease. So they would don PPE, take the machine in, take the picture, then carefully doff PPE, try not to get contaminated themselves, and then clean the machine so they wouldn't cross-contaminate anybody else in the emergency department or any other patients. And that was a 10-minute cleaning process. Now, if it was a good test, I think you can argue and say, okay, this is really not the most optimal way to manage care, but this is important. But for a test that wasn't very sensitive, it really was difficult to ask techs to go into rooms and risk their own contamination with a disease when the test they were producing for me wouldn't really help my clinical management. And so there had to be other alternatives. CAT scan, computerized tomography, is phenomenal. It's an amazing test. It's probably the gold standard for any pulmonary process. It's sensitive, it's accurate, and it can get a really impressive amount of information about a patient. The problem with CT scan, especially with COVID, is that getting a CT scan contaminated in a place where there was only one scanner would shut that machine down for hours. And so it's hard to think about scanning a lot of patients, especially when most of them don't have the disease and having that risk. So what else to do? For us, it became point-of-care ultrasound. There's a lot of data on lung ultrasound. There's a lot of data on lung ultrasound compared to CT scan that it's really about the same sensitivity in terms of risk stratifying patients for what disease do they have. And so it seemed like a more logical way to manage our patients was to have this. The provider who's going into a patient's room, who's already wearing the PPE, is going to be talking to the patient about what they have, has a handheld ultrasound system that's easy to clean, and it's incredibly powerful to risk stratify that patient in terms of what disease entity do they have. Do they have findings that look suggestive of a COVID-19 infection? Do they have findings that look more suggestive of another pathology, and we can adjust management that way? And can we pick up things that we can change our management for? And so we're really focused at that point in time in changing the paradigm. Instead of asking about doing a lot of different applications, the ask was learn how to do a lung ultrasound. It's a basic test. It's really simple to learn, and it can be incredibly powerful to go into these patients' rooms and really try and get a sense of what's going on and how should we manage them. And we deployed ultrasounds in all our emergency departments. We deployed them in the tents outside of the hospital, in the ICUs, and in the hospital medicine floors, just as an adjunct to have available, and really try and use these to answer those questions that we were asking about our patients. Providers still did their usual care. They still did the things that they felt most comfortable doing, but the argument was having this question asked early on with an ultrasound could really dramatically change how we were taking care of our patients and how we were using PPE, how we were adjusting downstream care. Now, so again, ultimately, the holy grail is learning how to do these applications. And I think in a rural setting, especially, understanding how to use applications is a clinical powerhouse with point-of-care ultrasound. But I've focused and I've reframed how I try to do education here on emphasizing the common things that we see, the common things that present on a daily basis. And for me, the sweet spot is understanding how to look at the lungs, how to assess a set of kidneys for someone who might have flank pain and potentially a kidney stone. Patients come with leg pain all the time. And of course, unfortunately, we see these patients coming in who've had an episode of low blood pressure. And how do you figure out what caused that low pressure quickly and easily in a way to manage them in a more effective way? So we were fortunate that we were able to get the administration to really support us having a third-party imaging platform that we were able to do a lot of education in multiple different sites remotely and be able to really work with providers on how to advance their skills. But I think the main thrust of this is that ultrasound is a technology which has been around, it's here, and it's incredibly powerful when used early on in clinical management. And the goal, certainly for me as an educator, and I think the optimal care in a system is to incorporate that and add this tool into a clinician's armamentarium that they can use it early, they can use it in a way which they're confident in their diagnoses, and they can change the life of their patient in terms of management as they manage their patients in front of them. So That's a quick overview of what we were trying to do here and why. Again, thank you so much for having me, and really looking forward to our panel discussion. Thank you again.
All right. Well, thank you so much, Dr. Weimersheimer. Adding in Dr. Kalman, thank you so much for being here. So kind of getting into the panel piece, really wanted to start by first off complimenting and thanking you for your clinical overview of kind of why point of care ultrasound is relevant, why it's necessary, but really how did you navigate, and then Dr. Kalman, I'd like your context from formerly being an administrator as well. How did you navigate, Dr. Weimersheimer, the hospital administration, venue of care leaderships to not only implement the program, but a business case maybe to put it forward for it making sense? And then subsequently, Dr. Kalman, what would be something as an administrator you'd be looking for from an ultrasound physician to provide to you to make the investments into point of care ultrasound?
Well, I think in terms of how to think about it from a business sense or navigate administrative support, there's a lot of layers to that. I think there's good data that there's a lot of risk management benefit from using point of care ultrasound. In other words, making a diagnosis early, risk stratifying what downstream tests are happening, how patients are intervened, all has a really profound benefit in terms of both patient care from the point of view of the patient outcomes, but also in terms of cost of management. But I think I was fortunate, and I have the administration here was really enthusiastic about trying to standardize care. So as I mentioned, emergency medicine, ultrasound is part of EM training, and it's considered to be a standard of care by the emergency medicine credentialing boards. And so we have a hospital system now of 7 emergency departments. And so the correct way to standardize care that where anyone goes to an access point in our medical system is that the providers there understand how to use this adjunct as they would at either in any system where it's done. So in other words, if a provider comes to a more rural setting or tertiary care setting, they're getting the same management and they're getting the same care. So I think that was for myself, there was a really profound support from hospital and network administration who argue that we should support that providers can do this if it's going to change how patients are managed in conjunction with all the other testing that was available at those sites. Jill, I'll defer to you on your version of this.
Thank you. And thank you, Peter, for that great presentation. You're saying what's the business case from an administrator standpoint, and having also the lens as being a doctor and always a doctor, but sitting in a health executive position. I have to say the business case is still, it's always quality. It has to lead with quality always. And if my physicians can actually make the argument around improved quality, and Peter spoke to a lot of that during his presentation, whether that's, and you saw many of those cases that could make the argument for quality. That's early diagnosis, risk stratification, early intervention. And I love the concept of standard of care. I think we really try to do that across the board. And this certainly leads to that. And then there's elements when you look at a business case that are, what are the efficiencies? Is it changing our efficiency in the emergency department? Is it changing throughput? Is it changing the ability to discharge somebody? Is it changing earlier time to admission? Is it actually really changing the workflow of more expensive downstream testing? So that as well. And then metrics. What metrics are we going to measure? Are those metrics that are pure quality, the ones that I spoke to, or is that also patient satisfaction, clinician satisfaction, our usability? In other words, are our clinicians using the technology that we're providing, which is always the case, and I think that's always more complicated than we actually realize up front. And then there is the finances. We do want to know, are there cost savings? Are there capital actually savings because we're replacing one type of machine with other? Are there actually revenue opportunities, cost savings, revenue, cost replacement? So that together, also in conjunction with potentially costs associated with implementation, which takes everybody's efforts on usually both sides, right? On a healthcare system side, as well as on a company side. And we truly try to put that all and really make a comprehensive case. And I'm going to say make a comprehensive case for quality, but also for innovation for care that really can change healthcare delivery. And that's how I often wanted to look at any business.
Yeah, and in my experience with rural and community hospitals, innovation is really big, especially they all wear so many different hats.
Right.
Having that leverage technology to make them more efficient and better, smarter, faster. So with that being said,
I just want to pick one more point of that innovation, especially in rural care, the ability to make a decision at the point of care. And that is a game changer for rural care and limited access care.
Yeah. So I guess that led me to the point that I just thought. So then what would you deduce down to being why POCUS is such an important aspect of the healthcare model in rural health?
Peter, do you want to start with that one?
Sure. I think, Jill, you really touched on a lot of that. As a practitioner in a rural model, in a rural setting, there's a lot of issues in terms of access. In other words, when I'm taking care of a patient, can I make the diagnosis quickly? Do they need a more advanced imaging assessment? Do they need to be transported someplace else? And so that concept of having that point of care expedited time to just assessment and decision making is really valuable. And especially, I work in a facility where we have limited staffing, and one or two patients who are really sick really changes the entire paradigm of care for all of us. And so being able to make the decision early on about a patient's acuity, about whether there's something that we can manage locally or have to transport elsewhere is enormous. I'd also say it's something that's really, it's hard to describe and it's hard to characterize, but the patient, both my satisfaction, but I think patient satisfaction is amazing. In other words, someone is coming in who has a specific question, and again, it may be relatively benign and maybe a really simple answer, but the concern from the patient coming in, they want to know why they are presenting with the symptoms they have. And what a profound experience that I've had as a practitioner, where I can be with the patient at the bedside, I can show them the picture I'm getting, we can talk about what I'm seeing, and I can say, boy, for instance, respiratory disease, your lung exam looks completely pristine. The likelihood of you having something more serious is really, really low. And you can see their shoulders just relaxed, and they are so much less nervous. It's not 100%, but just being able to frame something, that's why patients come to see us. They want us to be able to frame what we think in our expertise is happening to them that they're concerned about. And that's an amazing tool, an amazing adjunct.
Yeah, awesome. And I'll just pick up on that. I think when it comes to rural communities and healthcare, access is such a challenging element of how people get their healthcare. So any way we can provide access with technology, with innovation that connects clinician to patient, then patient back to clinician, and then potentially clinician to other clinicians with things like telehealth and teleguidance, are things that we should be using on an everyday basis. And I think that there's an element also of being able to treat patients in their communities. People are in communities for a reason, and they really want their care in their communities. So if we can empower rural communities for patients to be treated where they are by embedding the tools to do so, that really changes the health of those communities. And then I think with any diagnostic imaging, you're able to hopefully create earlier diagnosis and then earlier intervention. So we're talking a lot, with Peter about the acute elements of care, but then there's the ongoing elements of care. And so if we can bring imaging to communities, we can assess these communities for the things that they need for prevention or for common diseases, make assessments, help make diagnoses, bring care to the patients, and really change the trajectory of these patients' lives. And lastly, it's very hard to have a conversation without talking about COVID. But if we were able to bring some imaging to communities and make decisions for risk stratification and triage, that would be aided by other tools as well, that could also have very much changed outcomes of COVID in certain communities. So I think I can't speak enough about bringing these innovations to these settings.
Well, and I have one more question, and then we'll turn it over to the Q&A portion. But as we look at this, and I'll start with Dr. Weimersheimer on this, we look at the barriers to implement point-of-care ultrasound program within a rural health setting, or really any setting, but specifically here. Normally we see competency of providers, usability of leveraging point-of-care ultrasound devices, affordability, right? There's several barriers that we have kind of touched on today, but what would you say are some of those ways that we can achieve to get over those barriers, and that rural health organizations can strategize around, or what should they be thinking about to strategize around those?
I think, in terms of usability and obtaining the devices and affordability, ultrasound devices now are incredibly affordable. They're very powerful. They've evolved to really be more user-friendly. And I'd argue that when I teach, the first thing I'll tell everyone is just ignore all the buttons, just learn how to turn this device on and learn how to adjust depth and gain, and you are going to be a rock star. I think the biggest barrier is understanding the clinical benefit of having an ultrasound program, and understanding the clinical benefit of taking the time to become facile with the device. And that goes both for the providers, but also for administration as they're asked to support implementing a POCUS program. And all the things that Jill had touched on in terms of the benefits that can get measured. It's really having the cognition that if I take the time as a provider to learn this, I have another tool at my disposal that will really help me manage patients, and especially in a setting where I don't have a lot of other support, and I can do it locally without having to have a patient go elsewhere out of their community. And for an administrator to understand that if I support this program, my clinicians will provide a higher quality of care to the patients that we're trying to affect in a positive way.
Any other insights, Dr. Cummins?
Yeah, I would just add, I think that changing the way clinicians deliver care is difficult to change. And that's so for a clinician as well as a healthcare administrator. And to really create that groundswell of information like Peter presented today, this is actually the data that supports this utilization. So how do we really take this from a imaging tool to something that's just part of the physical exam, part of the stethoscope, something we utilize all the time that really can make a difference? And we understand that that's a challenge, and we're ready to take on that challenge.
Well, wonderful. Thank you guys so much for the panel discussion. We're going to now open it up to question and answers from the audience. Do we have any other questions out there? Did you like my ending? That's all I got.
Oh, it was beautiful. And you had this great smile on. I was ready to jump and ask you questions myself because I was so hooked.
It was my game show host.